So those of you that are here that attended, I'm extremely grateful for you guys because it makes my job so much fun to have such a positive, amazing group of people. I just have so much gratitude right now.
But it's that connection. Treating nerve pain is
Don't say it.
easy. We used to say the job's not done till the Meridians treat it. Well, if you listen, some cases with your fingers, some cases with your ears, some cases with your heart.
If his shoulder could be like a Rottweiler growling at you at the front door, that's what, you envision. But the story kept evolving, and it wasn't just about this 3-year-old accident. It was what happened before and before and before. You know what? There's 20 years of shoulder trauma.
Thank you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pittis.
Hi.
My favorite podcast
Ever.
of all time are the ones that we do right here.
Yeah, it's so much fun.
And the first time that we did it live, it was so strange because you weren't there and you were just here.
Yeah, and it's like,
There's
it's
something
so cool.
And as all the podcasts from probably November onward are leading up to the advanced events, and it's like Christmas Eve, and then we're finally here. Advanced.
I know.
And there's a palpable energy that happens here at the Crown Plaza.
When people start arriving and you walk into the lobby and you see all these familiar faces, like, I've known you for a really, really long time. And it's the biggest family reunion. Did it get dark?
We got dark on the screen, but I don't know if we got dark in real life. But as long as it's looking fine, and
yeah,
I think we're okay.
Bodies.
Yeah.
There's an empty chair up here if you want.
Come on and stick in.
There's
So
more.
instead of having our Zoom family audience, we have actual live family audience, which is great. So same rules apply. If you have a question, you don't get to shout it out, but we'll pause and have question time because questions and stories are just where it's at. And you're doing the same thing that you do when you're in Portland, I'm in California, and it's just like, I have a story to tell. I have stories to tell too.
You tell yours first.
I am just still running on positive energy from teaching my 3-day sports course. And I am extremely grateful for this group. It was one of the biggest groups that we've had.
No, it is the biggest group you've had.
It is the biggest group. Ireland was quite big too, but this was a great group, but one of the smoothest when you don't want to say something too soon. So my travel here was really smooth. My plane was on time. Everything was just smooth. And then I thought, yeah, I'm going to have the craziest group of sports core attendees. And there's going to be some sort of like crotchety know-it-all, or there's going to be some, and we didn't have any of the unusual characters that it was just a phenomenal group. So those of you that are here that attended, I'm extremely grateful for you guys because it makes my job so much fun to have such a positive, amazing group of people. I just have so much gratitude right now.
I got to the end of 5 days of core and it was smooth. I'll tell one of the stories about how one of the cases ended up being 8 slides in the advanced.
Oh, that you just inserted.
That we just inserted. Just so you know, I haven't finished the advanced yet.
And so you sports core people understand how my mentor has created why these slides don't match your presentation.
Yeah. And Kevin says, yeah, they really mind when the slides don't match what they have. And it's not my fault. It's not his fault. It's my fault. It's because you go through the slides just before you go to present them. That's not right. What was I thinking?
Or it changed, right?
Or you learned something.
Right.
And then you go, that, as a matter of fact, I did that on the fly one time in the middle of a course where we always do the physical medicine, then treating neuropathic pain, and then the central nervous system. And the segue between the peripheral physical system and the central nervous system was like obvious. So in the middle of the course, I went to the central nervous system, grabbed, I don't know, 30, 40 slides, copied, paste, and then we just moved right along. It's, wow, why didn't I think of that 10 years ago? It's okay. But it's that connection. Treating nerve pain is
Don't say it.
easy. So I just visited a friend here in Phoenix, and she has somebody living with her who's like only 72, who's had diabetic peripheral neuropathies for maybe 15, almost 20 years, but they got really bad about 3 years ago. And now she can't feel her feet. Her pain level's a 6 or a 7. They gave her enough gabapentin that she's fallen and had 4 concussions in the last 8 months. And I actually said out loud, it's like diabetic neuropathies are easy. It's like
Then do you wait for the thunder and the lightning?
lightning never strikes. And so why would you not segue from physical medicine to the central nervous system? Because the central nervous system controls everything you are allowed to do in the musculoskeletal system. Starts up here. This gets in the way, but it's this whose job it is to protect that. And then treating nerve pain is so easy. Why would you put it there? So anyway, so the nice lady, I have a custom cared program tonight, plus finishing my slides, but I promised to finish my slides first. And then, yeah,
Let's face it, the slides are never finished.
no,
It's an ongoing, ever evolving piece of information that just keeps growing and growing.
and God bless the person that said, can we have
A 4-day.
a 4-day advanced?
Yes.
Because I used to just blow through it. It's okay, this is how you think of things. These are the heavy metals. These are the miasms. Have a nice life, goodbye.
Right.
And now we have 4 days. So I added a
Bunch.
of stuff. And some of it I added in the beginning because I promised you wouldn't miss anything because you're lecturing on the second day. And it's okay, I can do that many slides each day. So I have to get to this slide before I get to the new stuff.
Yes, please.
So the new stuff is coming on the 3rd day so that Kim can start, because
And for everybody too, because we shouldn't have to choose.
there's
We should
that.
just get you.
I know.
We shouldn't have to choose you or me or you or.
I just
Patrick
have
Snack.
the idea that it's not nice to make people that have heard me. How many times have you been to the advanced? You
A
know,
lot. But
lot.
if there's new stuff, I think we should all have an opportunity to see the new stuff and not feel obligated to choose to miss the new stuff.
Exactly.
So you listen to me.
I had some more stuff early on so that by the time I get to the new stuff
We can all.
on the energy centers,
Yeah.
we have never done that before. When do you treat them? And the acupuncture meridians, they cross the shoulder, the hip, the spine. And Harry used to say, he used to use acupuncture or microcurrent probes to stimulate the acupuncture meridians. And he used to say, the job's not done till the meridian's treated. I don't know pulse diagnosis. And it wasn't until last year sometime in one of the cores, we had an acupuncturist that does pulse diagnosis. And he was not definite about whether it was damp or weak or tinny or whatever. And I said, what if we just use the frequency 35? You know how we use 35 and 102 to balance the crown? What if you use 35 to balance the meridian? He said, I don't know, try it. So I took the precision care and I went 35 and whatever meridian. Usually it's kidney, spleen, lung. Acupuncturists in the group, right? Kidney, spleen, lung. So we did kidney and he went, and once they do that, then you know you got it. and then spleen, and then the lung is the mother of the kidney. And once you do the lung, all three of them settle down. Hi, JJ. And so there's a section on the energy centers and a section on the meridians. And then we had actually two events, but there was only one that I turned into slides, where the practitioners that were treating this patient's abdomen did adhesions in the abdomen, as you would after a traumatic C-section. And the C-section was traumatic because the baby got in trouble and mom was agitated and upset. And now the baby's like older considerably, so it's been a while. So they did the adhesions and they did inflammation of the fascia to settle everything down. And then they did 970 and 27, which is as terror. Sometimes emotions are so strong that your brain and yourself just put a lid on them. It's, yeah, you don't get to open that box. We're going to keep the lid shut. You keep it in a box in the closet under the shoes, and then you run 970 and 27 and open the box, because you make the emotion less strong, so it doesn't have to be so strongly suppressed. Does that make sense? Everybody know what I mean? Mm-hmm. All right. So they did that, at which point the patient totally lost it, started sobbing, laid down on her side, curled up in the fetal position, crying. So they called me over. Thank you very much. And we had a precision care, and I had Jessie Brader standing there. One practitioner had a hand on her hip, another one had a hand on her feet. I didn't even have to tell anybody, don't say a word. And we just worked through it. So strongest point, start of the emotions, is the midbrain. So we just 40 and 89, the sobbing got less, and the trembling got less. Let's see if we can get away with 970 and 27. More sobbing, back. Anyway, back. Short version is 45 minutes, an hour, roughly, bouncing back and forth between trying to get back to being able to run the emotions, balance the solar plexus. So you think of the solar plexus energy center as its identity, but it's also survival. And she thought she was still connected to the baby. So when the baby got in serious trouble, she thought they were both going to die. Some part of her thought that. So you got to balance the solar plexus, sobbing and trembling. Okay, fine. Didn't do that. So we went back through a series, went back to the solar plexus. This time we got away with it. And then, so that's ended up being 4, 5 slides in the sequence after the energy centers, after the meridians. There's one slide that reminds you what the emotions are for. And then happy ending to the case, yay. And then what do you do if it happens to you? Because hasn't, in 30 years of teaching the core, it's never happened. And we had two nights in a row. One that night that didn't take as long, and then the second one the second night, and it went on for long enough that I saw what we had to do to get her out of trouble. And so that's what the advanced is about. And then we do heavy metals and miasms and all this stuff. Don't look so scared. It's going to be fine,
But
really.
I'm going to pause you the way I normally pause you on the podcast, because my favorite thing is we have a little bit to unpack here.
Yeah, unpacking.
So what I'm hearing a lot with what you're explaining with the emotional frequencies and just the load that they carry in moving in and out is very similar to what we do with connective tissue, because People that have been taught by me know the famous lasagna slide, where the frequencies are layered. And the same thing works with emotions, right? It's not like there's a one size fits all recipe where you have to run 40 and 89 and then this and then that. Although you have talked about certain emotions should be run first.
Yeah.
Like anything, it's great to have a recipe to follow, but have the knowledge to know, okay, if you don't have all of these spices, what can you do to adapt and make this recipe fit the situation?
Well, in the patient response, so when we start working on the subscap or the psoas, how do we know we're in the right place? We look at the patient's upper lip or their eyebrow. If they make scrunchy faces, you know you're in the right place. So the patient feedback, the patient will tell you what to do.
Right.
The shoulder, as you get to torn and broken in the labrum, and you just position the humeral head. Oh, you made that made you happy?
No, because I have a story.
Oh, good.
I get to tell a story.
And
after this.
when you get the shoulder in the right position and the muscles relax, the humeral head just sinks right back in the joint, and you're all good.
Right.
And it's like the body will give you feedback if you listen, some cases with your fingers, some cases with your ears, some cases with your heart.
There is a certain intuition that happens, and the lesson for the sports course is when it came time for us to do our supine or our shoulder practice. I show options to treat the shoulder supine and lateral recumbent because we move a lot. We want the shoulder to move. Treating prone is great, but you don't get to move and see and supine. Of course, you ask, would anybody like to be my volunteer? And the people that typically have the injuries come hurtling over the desks to get to the front of the class.
Trampling people.
And so we had somebody that came in with shoulder pathology, and all he had disclosed in real time was he had pain for 3 years, partially torn labrum from a motor vehicle accident. And so very stoic, an athlete, not a big deal, thought, oh, I just hit somebody. I'm like, what was the impact? Just hit them like this. And then as he unravels the story, somebody came across 7 or 8 lanes of traffic and then stopped, and then he hit them. And so the impact of the shoulder, the impact toward the labrum. So you go to the usual suspects treating the labrum and his entire rotator cuff, and all I can do to explain it was like that shrink wrapped slide that I have. Everything just felt tight doesn't even begin to explain the
protected.
Yes.
Don't touch me. Go away.
Yes.
Don't move me.
Yes. If his shoulder could be like a Rottweiler growling at you at the front door, that's what, you envision. However, all the frequencies that I was trying to teach, the torn and broken and the labrum and the trauma and the fascia and everything, nothing was really, sorry, we didn't do trauma so much, but the torn and broken in the labrum, if the shoulder was reacting because of the labrum, it should have softened. And when it doesn't,
that's not it.
That's not it. And that's where the point of like listening with your hands. And what's our favorite? Less motor and more input. So it's not about telling the tissue. Like in the old days before FSM, I would have just kept working. I would have just pulverized it, made it my subjective person. Just
listen up.
Listen, exactly. And so because it was a practicum, we had to move off of it. But of course, I had treated him from 4 until, we ended at 4 yesterday until 6:30 after the class.
Surprise.
Because it couldn't stop. You can't stop till you're done. But the story kept evolving. And it wasn't just about this 3-year-old accident. It was what happened before and before and before. You know what? There's 20 years of shoulder trauma. And that's what we had to get it. So it's layers, and it's no fault of your own as a practitioner. You only get what they give you until they give you more information and more of the story.
And we had practitioners obviously worked out, very muscular. He said, oh, I have bicipital tendonitis from, I bench press, how much? 150, 180, it's okay then. And so I felt his biceps. So he was the supine shoulder demo, because he had limited range of motion and everything bunched up. And so you don't have sensory exams, you don't have reflexes, so I didn't have data to work with. All I had was I bench press. Okay. And so I did his subscap, and we got up to about here, and everything like just went, eh. Let me check something. And you go between the SCM and the trachea, and right there, he went, ow, ow, okay. And then we felt his legs, and that slight loss of descending inhibition, increased tone. He doesn't work. He's got well-developed muscular quads, but nobody works on their pectineus and their brevis. So that was rock hard. And so we set up another machine just doing increased secretions in the spinal cord, and his legs smoothed out. And we had another machine that was working on the 5-6 disc. I said, the problem with your shoulder is the 5-6 disc. Excuse me? So we treated the nerve, treated the disc, went ahead and treated the shoulder, then the labrum, and the shoulder finally settled down because the problem with the shoulder was the 5-6 disc. And it's like, how did I do that? No auto accidents. But if you're bench pressing and you do this, and you think of the disc as a jelly donut, and you've got flexion on the front, jelly, he doesn't have any arm pain. He's got tight muscles in the shoulder, but his tight legs tell you that it's a broad-based central disc inflaming the motor pathways that provide descending inhibition that keep your legs soft. Right. And I looked at him. So he's an MD and he's a bodybuilder. So what's that tell you about the way his brain works? What do you mean I have to stop lifting weights for 6 weeks? And it's, you have a sprained ankle in your neck. That's what a disc is. It'll repair itself in 6 weeks as long as you don't do anything stupid. Excuse me? Stupid means bench pressing. What can I do? You can do legs as long as you don't do that, and as long as the tone in your legs is normal. What do you mean? So I had him feel his pectineus. Oh, those are really soft. They're supposed to be soft. Oh, okay. And then you explain. So a lot of what we do is patient education. Then you explain, you have to repair the disc. And if you don't, like right now, you've gotten away with it, right? You don't have a lot of sensory changes, but your legs wouldn't be tight unless the disc was pretty close to the cord, close enough that you're interfering with descending inhibition. This means you got lucky. Don't push your luck. Should I get an MRI? If I would, and if you can order it on yourself, because you don't have enough physical findings for anybody else but you and me to order this MRI. Would it change anything? Yeah, it would. It would change how careful you have to be. Where is the disc? How big is it? How close is it to the cord? I'm just going on what your physical condition tells us about the disc. Your legs are tight. That's a thing that wouldn't be there unless the disc was inflaming that descending inhibition. And all it has to do is slow it down. You're not spastic. You just have loss of descending inhibition. Oh, so when you explain about the jelly donut and about the descending inhibition and what the risk is if they don't listen to you, you got 6 weeks to not, maybe 8 weeks, not to do something stupid and to use your custom care every night for disc repair, treat the nerve, and run 81 and 10. We're talking every night, at least disc repair. Okay. because he knew what the risk was if he didn't. And that's the patient education part.
Right. Patient education is a huge part, whether you're dealing with athletes or the aging population, right? It's all about, no, my balance protocol
Yeah.
is all about, we are all getting older. We all need to work on our balance. And we had the conversation about reactivity, right? When we are falling off of a curve, we need to have the proprioception and the reactivity to catch ourselves so that we don't fall and we don't break things, right?
Quick twitch. Try saying that 3 times fast.
I can't.
Quick twitch muscles.
Right.
As you get older,
Yeah.
turn into slow twitch muscles. So you just can't change that progression,
Right.
but you can train them and train the proprioceptors.
Right. And so what we did today was all patient education. There's stuff that you do in the clinic, but you don't get an excuse to not do balance training, because I said the only piece of equipment you need are your eyelids. Eyes open versus eyes closed. That's proprioception.
Yeah. Unless they have Meniere's, at which point they close their eyes, they fall over.
I would catch you.
Okay. Thank you.
But what I'm saying, patient education, I think, is a huge component, and teaching people to use their custom cares. And in a lot of cases, it's not just plugging it in. It's, you can move with it. You can train things with the support of the custom care. And that's where I've seen a lot of cases being closed. You don't want to hear the patient that got better in your clinic and then came back next week and everything went back to the starting point. You're not a one-trick pony. It's all about staying healthy and moving as long as humanly possible.
Exactly. And this phrase you started using, feeling safe, that's when we started using 40 and 89 at the end of any treatment where somebody has had pain in any joint or limb.
Yeah. Or has had an extreme change in range of motion. Right?
Oh, yeah.
Sometimes when you do that, your nervous system is just can't compute because it happens so quickly.
Yeah.
And I'm very grateful for 40 and 89. And I can't imagine, we keep talking about this island. If I go to this deserted island and I get to bring 5 A channels and 5 B channels, and it has changed a little bit. So I would like to use this opportunity to talk about your 5 favorite A channels. Not 5 favorite, the only 5 A channels you get to bring.
Oh. 40.
Okay.
124.
Yep.
That's new.
Yep.
81.
Okay.
49.
Yeah, I should go one more left.
Probably trauma.
Yeah.
And actually probably nerve trauma.
Okay, you can take the 2 traumas. They can go together.
Okay.
294 and 94. They can
Did I get it
together.
right? Do I get a piece of chocolate?
Yeah, we ran out of the chocolate. I would, you have a whole box of chocolate and a story to talk about that.
Yeah.
It's not about getting it right or wrong. I'm very similar to you. I'm not taking 40 because I'm just not.
Okay.
I've got some alternatives for 40. So I am taking 124.
Absolutely.
Right after 124, I am taking.
Oh, 13.
Yeah.
Damn,
Hey,
that's that one.
That's who's jumping onto my canoe to get to the island.
Excellent.
124, 13, 49, trauma A, trauma B, whatever, 294, 94.
I take it back. You're right.
Okay.
Because if you fix 124, 40 goes away. And if you fix 13, 40 goes away.
And if we get an infection on the island, we don't know if we want 40, because we're going to trust, because we have 49.
Yeah.
We're going to trust on our B channel. The Vegas is coming with us.
I was going to say, because Vegas get on the boat.
Okay, so now we have to take the B channels onto the boat with us. So you go first, B channel 5. Vegas.
109, the Vegas.
Yep.
89.
Yep. Midbrain.
10, spinal cord.
Yep.
84, the cerebellum.
Okay.
And 90 or 92. Can 6 people get on? 6? No?
Fine, only because it's you.
Okay. Oh, and I forgot 396.
Too bad. You have to make a choice. Only one more room. We're going to need a bigger boat.
396 is fair.
So you can tell who the neuro geek of the pair is, right? She's taking all of her brain with her. I'm not.
Go ahead. Leave the brain.
Number one.
You have to have 77.
Okay. I said, okay.
Yep. Okay.
Number 1, people want to shout out what they think I might take with me on my boat. 142. Yeah. 142 is coming with me 100%, because the more I know, It's everywhere. So I want everything to get treated all the
Fair
time.
enough.
142.
Oh,
396 coming right after.
396.
I want my
because 396 is connected to
It's
142.
connected to
True
142.
story.
Yeah,
Which is
exactly.
connected to 10, which is connected to 84, which is connected to 92, but that's another story.
What do I have? I've got what?
142,
142,
396.
396. I'm taking 89.
Okay, good.
I need
Yep.
to take my midbrain with me.
Yeah.
Connective tissue might be,
77 is
yeah,
gotta-
77 is
because
coming
the- yeah.
because of the fascia and the nerve. So I need to bring that. It's really hard. And then 109. Oh my God, how did I leave the Vegas
Yeah.
at home? He's
Yeah.
coming with me. So
10.
we're pretty close.
Yeah.
You have a little bit more of your brain. I
Then
have a little bit
I
more of
kinda-
my connective tissue.
Yeah.
But together, we'll be just fine on our
As long as both of us are on the boat, we're fine.
Yeah, as long as our boats are together. I don't know how we're getting to and from the island, but whatever, we're taking
don't
those.
know.
And I think those frequencies actually have changed a little bit in the times that the 200 podcasts.
Oh,
that
in the
we've
last
done.
10 years for sure.
Yeah,
When have we been done? How many? When did 6?
we started the podcast during COVID and we've had 200. So
so
that's 5-6 years. We've
6
started.
years?
Yeah.
So we've learned a lot, even in the last 2 years. The
Correct.
core has just,
Yeah. Well, yeah, even my slides with the labrum, a couple years ago, I wasn't totally sure 214 was labrum. And so a couple of the keeners in the group were like, you still have 77 and 157. I'm like, oh yeah, no, it's 214. I believe it.
yeah,
Labrum, meniscus.
it had to prove itself.
It
Because
did, it
it
did.
started out as meniscus with a little I next to it.
Right.
And then as meniscus, it went away.
And now
And
it's
then it was
labrum-y.
the labrum. The labrum in the shoulder was the first one.
Yeah.
And then the labrum in the hip is, okay, I give up. The little I goes away.
Yeah, 100%.
Yeah.
And then people have been playing with pubic symphysis as well with 214.
Ooh.
And the new one, the thought experiment that came up was the TMJ disc is also that fibrocartilaginous.
Yeah, yeah. Oh, and then
Put
this
that one
year,
out there to all of you.
one of the instructors or practitioners said, oh, you know what really works great? You ready?
I'm ready.
18 and 710.
Bleeding,
Now, leaking.
leaking.
Blood vessels, if it's a blood vessel and it leaks, it's bleeding.
Yeah.
But 18 is also
Leaking.
leaking. And it's get out. Now try it. And the instructors were the ones that took me from 40 and 710, inflammation in the disc annulus, to torn and broken in the disc annulus, at which
100%.
point everything goes smush.
Yeah.
And I haven't, they always tell me this as I'm headed out the door. So I haven't had a chance to try 18 and 710. But when that instructor says, you should try that, I've learned to listen. So
Yeah.
there's that.
Somebody wrote on the chat 91. I'm not sure if they want to bring 91 with them. I'm not though.
No,
make
I
91.
wouldn't.
13.
And 217, actually, if there are old people on the boat. 91, because
What's
I
our
don't
boat
know why.
demographic?
there's
Yeah.
not.
Yeah, so yeah, it's just it's evolving, it's playing. There's enough of us that are trying things. I think that the anecdotal evidence piles up to a point where you just can't unsee it anymore and it just keeps working.
Especially if you see the data that we have on the vagus now.
Right.
I don't even treat 40 anymore.
Right.
I run
See,
concussion and vagus or vagal tone, and I let the vagus decide how much inflammation I need.
I might have just been saying that for 3 days.
It's like in the air.
Right.
Why
Right.
would you do that? It's fun when you have somebody with rheumatoid arthritis who comes in with a knee this big and you just need to get the thing from grapefruit to orange.
Right.
That then use 40 and that's easy.
What is the saying? Necessity is the mother of invention.
Absolutely.
And so that was why I started my experience with 40 was starting to really get into the world of sports performance and orthobiologics, where you can't use 40 in the neighborhood of
Tweaks.
PRP. And so then it's, okay, gun to your head, you can't use 40, start thinking about other things. And then
You
it's
can't use the vagus either.
you
Can you?
can.
It's allowed.
It's allowed.
Okay.
It's a little vitality in the vagus. It's like little Roger Billick.
Just,
Give it a little
Yep.
bump. Just give it some support. It can do its job better.
yep,
Just
been there,
keep-
done that.
But I think one of the things I'm grateful for is you teaching us how to think about everything. And it's not just this recipe. No, the tendon is not inflamed. It is actually torn and broken. There is trauma. There are so many things that happen to it so that it needs the orthobiologic to help it heal. So our job is to just support that healing as much as possible.
And I have to give credit where credit is due, and that's Diana Cross.
Yeah.
So we didn't understand why 124 and 191, or how 124 and 191 healed my Achilles tendon from 2 thumbs to that big in 60 to 90 minutes. Huh? How did that happen? So she went home after I presented that, and she did the research. And when the tenocyte, the tendon cell body genes, detect a tear in their connective tissue attachment, which forms the tendon, those genes say, whoa, that is torn. We can fix it so she won't use it. So the genes change and begin to secrete CGRP, calcitonin gene-related peptide, which hurts like hell. Substance P also hurts, and interleukin-1. I think those are the 3 that are in the research. And so it hurts. As long as it's torn, it will continue to swell and continue to be painful. And if you keep trying to push through it and you tear it, more genes turn on in more cell bodies, and you go from this big to that big. How do you fix it? I'd already treated inflammation for 10 months. Didn't work at all. Kathleen Casbin used, ew, that feels icky. And she used 124. And we sat and talked. And she just, that was back in the graphite glove days. And she just talked and treated. And I said, wow, doesn't hurt anymore. Yeah, it's getting smaller. And we talked about the garden and the kids, and she just kept treating. And pretty soon, it's this big, doesn't hurt. I slept with a pillow at my feet, followed my directions, did a little, I'd already been doing eccentric, which is supposed to heal it, didn't. And that was it. It was done. Never needed another treatment. Okay, fine. And then didn't understand why for 3 or 4 years until Diana Cross came up, and she had actually looked up the genetics of why we would take 124 on the boat, but not 40, because 40 is not the problem.
Right.
124 in the connective tissue or the round tendons, doesn't matter what's torn and broken. The genes turn on and begin to express the genes. Every cell in your, this is mind-boggling to me. Every cell in your body, when it becomes dysfunctional for whatever reason, has the ability to turn on the genes for inflammation. So this patient with the diabetic neuropathy that I was talking about, the one I saw today, did you get COVID? Yeah. About 21 or 22. And when did your neuropathy get really bad? About 3, 4 years ago. The vagus is turned down by infection, stress, and trauma. That's number 1. Number 2, the virus goes into the ACE2 receptors in the blood vessels, replicates, and they come trampling of the blood vessel. Biker dudes that trash your lawn, they just trash the endothelium on their way out. So what are diabetic neuropathies about? The blood supply. Okay. Why did it get so much worse 3 to 6 months after she got COVID? If the blood supply isn't right, then what happens to diabetic neuropathies? So when I program the custom care for peripheral neuropathies for her, it's not just the recipe for diabetic neuropathies. You have to add the frequencies for the flu viruses, right? Because it's that pattern, and we have to add a sort of lawn reconstruction, vascular repair, because you had a bunch of bikers that trashed the endothelium on the way out. So that her peripheral neuropathy protocol is going to be different than the recipe. The recipe would help, but not as fast. And she needs to feel better now. I can do that.
To add, not to unpack,
No,
but
yes.
again, to emphasize part of the story that is my job to emphasize. And
Yeah.
I feel like
Clean
you
it
write the
up.
text and I just come along and I just keep like highlighting what I want people to highlight.
Thank you.
It's the story, it's the why, it's the how did we get here? It's not necessarily what's the pathology, what's the tissue. It's taking the pathology, what is happening, where it is occurring, but the overarching question is, how did it get like this? And I think that, like you were talking about, not just accepting the fact that there's a diabetic neuropathy and these are the frequencies for diabetic neuropathy. It's, when did it start? Why did it start? What else was going on? Like when you start asking those questions in the history and you start connecting the dots, that's why we treat trauma. Like when we're talking about scar tissue, it's not just, okay, 13's working, that's great. But you didn't get scarred from outer space. And before it got scarred, it probably got torn. That's 124. Before the tearing,
It was
maybe
bleeding.
it was bleeding. There was paralysis. And how did it get like that? Maybe there's trauma, right? So it's asking the questions to lead you up. And it's not that you're wrong just treating scar tissue. It's just that you have a lot more of the story to go back and fill in and to close the gap, or to sometimes when you're plateauing with the treatment, things aren't getting better. And it's going back and asking more
You
questions.
start asking, it's like your fingers run into something that don't make sense.
Right.
And that's why the phrase in the core is over and over again until you really hate me. See with your fingers. Use the flats of your fingers. And there was somebody who's kept doing this. It's no, the flats. But this is what I do. I understand that. But look at the homunculus in your brain. The finger tips, the flats, the pads of your fingers in that homunculus are huge.
Yeah.
Not the fingertips,
Right.
the pads.
Yeah.
So we treat this way, which was really fun because we had somebody who couldn't do this because she couldn't supinate. What nerve runs a supinator? So in order to fix it so she could do this with her right hand, we wrapped a washcloth around her neck and put a washcloth around the supinator, and we ran 40 and 396. Quiet the inflammation on the nerve. I found the disc, it's right there. We did 40 and 396, the supinator relaxed, and she said, oh, I didn't, how did you, okay, fine. And then it's 1 and 1 is 2,
Yes.
and then 2 and 2 is 4.
It's just thinking about the story and thinking about the story, listening, asking the right questions, but then to piggyback on what you're saying, it's not telling the tissue, it's listening to the tissue.
And seeing inside. It's like you know what the anatomy is.
Yeah.
See it
Right.
with your fingers.
And listen to what it's telling you.
And it's torture.
Yeah.
I just love torturing massage therapists, osteopaths, chiropractors, physical therapists, the poor things. 18 years in practice, and they just thought they were coming to learn frequencies.
Right. No. It changes everything from your speed of your treatment, the palpation, the slowness, the depth. And then now with exercise correction, it's also cutting it way back. We don't need to they
Yeah.
fatigue faster. You have to pay attention. It's just different.
All goes together, which is why the rehab class was inevitable and
So exciting.
excited.
So
And
grateful.
I'm, yeah,
Yeah. It's that time when normally my little alarm goes off that
we have 15 whole minutes.
so my alarm normally goes off at 4:30 and it says check if there's any questions, or sorry, at
Oh,
3:30.
Do we have
We
questions?
don't have any questions here, but I'm sure we
But
have a lot of people,
everybody's-
so we get to turn the stage on for some questions.
Came up, or some comment came up in the class.
Yep.
For young people, I have a mother that called, I guess they had mold in the house, and her 6-year-old is really affected, make an appointment. And then somebody told me with the child, you really 20, 30.
So the question, I'll just repeat the question, talking about treating kids and what like amperage
Yeah.
I'm trying to disclose to treat kids. And the suggestion was 20, 30.
So the question was about amperage. So if you're dealing with I used to say 20 or 30 microamps on like a 1-year-old or a 2-year-old on an infant. And then I worked at Cleveland Clinic, and that took care of that. There's Ben Catholi with 7 machines running 100 microamps on a 3-year-old. Okay. And the kid was just fine.
Yeah.
So on a 6-year-old, you've got body weight of what, 70, 80 pounds, give or take. They're this tall these days. And I'd use 100 micrograms, it'd be fine. And you have to understand, if the kid has been affected by, exposed to, and affected by, which are 2 different things, because there's only 25% of the population that the immune system can't handle, dispose of, excrete mold. So there's 4 people in the house, he's the only one that's affected. They have to remediate the house if they want to keep the kid in the house. And FSM is to be used as an adjunct. You have to treat the mold in the child. So you do urine mold testing, find out which mold you're looking for. If it's Stachy, Botrys, or trichothecenes, you're looking for something wet and black. Okay, there's that. If it's Aspergillus and Penicillium and the other one, you're looking for moldy stuff like drywall and plants. Oh, the house is full of house plants. There's carpet everywhere. And you live in Portland, you know, the what? It's San Jose. The carpet gets wet, the pad gets wet. What grows in there? So you have to think. So you have binders, and then it depends on who's doing the therapeutics. If it's Neil Nathan, you'll do binders to keep the mold from recirculating in the gut. And then we have frequencies for mold. We have frequencies to get the vagus working again. And then some people will use itraconazole or an antifungal, some conazole, to kill the mold. If your therapist is shoemaker trained, they don't use antifungals. That's a whole debate we just leave over there. I'm an adjunct, thank you. And you use FSM as an adjunct. Get the vagus turned back on, treat whatever part of his body has been affected by the mold, tends to colonize the sinuses.
What about the liver?
And the liver mostly recirculates the mold. I've got enough people in here to check. If I get something wrong, they'll tell me. Yeah.
It'll try to put a hydrogen group or water molecule on it, make it water.
Say again?
soluble. So then it goes to the kidneys to get.
So it's going to add a water.
Oh,
Water to
Yeah.
the kidneys.
so it gets excreted through the kidneys. Is that what you're saying? Yeah.
If it can make it water soluble. If not, then it would go into the bile.
Yeah. So if you can make it water soluble, it goes out through the kidneys, which is why we test for mold toxins in the urine. And then biggest problem is it goes into the bile, which goes into the gut, and then through the hepatic portal circulation, it gets recirculated in the GI tract, and it never goes away because the immune system can't get at it. So,
The MD referred her to go find FSM.
oh,
for Rick, so
yes.
I haven't talked that much to her, so I'll find out what I'm sure he has some protocol he's using, but I'll explore that.
Who, the FSM practitioner?
No, he's not, it's guess a doctor, I think he must be in.
So the MD is treating the mold and he's sending the child for FSM. Yeah, and you're the FSM guy?
But
Yeah, you don't ask the doctor because the doctor has no idea what you do. But if you watch the mold webinar, you will know what to do, and that's on the website, and you have unlimited access to it. We're so nice. Thank you, Kevin. There we go.
Another question, yes.
Peripheral neuralgia, diabetic, say we run the flu virus then after that. Would it be the same after the shingles, like peripheral neuralgia after shingles? Would you run the flu as well after that?
I'll repeat the question for our podcast listeners too. So we're talking about the story with the diabetic neuropathy. You were suggesting to run the flu frequencies because we were tying it to COVID. And so I believe I understood the question to be, if there were a case of diabetic neuralgia following shingles, would it be important to run the shingles frequencies as well? Oh, sorry, the flu.
No, the completely different class of viruses. So the herpes family is much smaller. It's a crystalline 783,000 Daltons. I just remember that number because it's small. The flu viruses are bigger and heavier and have those little spiky things hanging out. And the herpes family is just different. I skipped virology in pre-med and I regretted it ever since. But if you look it up, you can see the difference. So if they got the COVID or the flu or a vaccine is an artificial infection, it's exactly the same whether they got COVID or whether they got vaccinated. It's an artificial infection. It does what it's supposed to do, which is exposes you to the virus. We're not even going to get into the whole mRNA conversation. It exposes you to the virus so your immune system can develop a reaction to it. So does that help? No. It's like shingles is shingles. The flu is the flu. So post-herpetic neuralgia does not affect diabetic neuropathies. Does that help?
Yeah, I just wonder how that will help that then the peripheral neuralgia with after shingles.
So getting peripheral neuralgia after shingles.
No, they won't. So post-herpetic neuralgia after shingles affects just the nerve root that had shingles. It doesn't go down and affect the blood vessels that give her diabetic neuropathy down here. 85% of shingles is in the thoracic spine. The other big percentage is in cranial 5. And then the upper, but you can have it in any nerve root. I've seen it in L1, but statistically, 85% happen between T1 and T12. And so you treat that nerve. It doesn't affect the blood supply, and COVID affects the blood supply, and that affects diabetic neuropathies. Does that help you think about it? Yes.
She's not going to say,
I got it
no,
right.
just in case.
Yeah.
So we have one online. We'll get to the
Yay.
other ones. I just want to make sure that our online person, we've not forgotten about you. Says, if someone had a tooth knocked out while in the ocean surf and placed back in immediately, so I'm assuming tooth is out and then they just shoved it back in.
Wait,
I'm just reading this.
Okay.
If someone has a tooth knocked out while in the ocean surf and placed back in immediately, what thoughts do you have to support the tooth area? There already was a problem with that tooth being loose anyways, due to the impact of a truck accident. And years ago, which had been changing impact on teeth, although this was being addressed and there was a great loss of the alveolar bone. Thanks.
Where's Mary Ellen when you need her? She's
So-
lecturing someplace else.
A tooth knocked out and they just shoved that back in and your computer just died. So that's it for the online questions.
There's a frequency for rational thought. I'd go to that one first. So you're in the ocean, which is not exactly a sterile environment, and you have this tooth come out and that was loose to begin with. So here you are with this tooth, and you have a hole in your gum, and you put the tooth back in, and you've got salt water, whatever bacteria is in the water, and you don't want to talk about that depending on where you are. And yeah, no, no. You go to a dentist, you have the tooth, no. Okay, boundaries.
It's gone.
Boundaries.
But the bad question's gone. Okay, studio audience, yes, next question.
Not a bad question. It's
No.
like recognizing boundaries. You can't do, I swear to God, somebody asked me, do we have frequencies for vitamins? No, we have vitamins. It's like that you actually need the physical stuff.
All right,
Okay.
next question, yes.
We talked about the wipe and load in the
Yes.
sports course.
Yes.
And we talked about using the load frequencies.
Yeah.
Sometimes without using the wipe ones.
Correct.
Do you have to use them like in close succession, or could you start a session and do the wipe and then not do the load until after, or do they always have to be close, or would you just do the load frequencies?
It's finally a question for me.
Okay.
So wipe and load, this is a concept that we do in the sports course. The wiping is saying, remember this pattern, this was really bad. We don't want to enforce it. And then using 81 to load an optimal pattern once somebody feels safe in which to do that. So I like to load, I don't like to leave people feeling vulnerable or unsafe in a movement pattern, whether that's moving something or just feeling unsafe leaving the clinic. Like I will stay and work late until the pain is down and they're feeling good in their skin and that the limb feels as organized as possible. So yeah, I would probably put the load right after the wipe because we don't want to feel anything, just feeling unorganized or uneasy. And to the other part of your question, yeah, once we have movement patterns that are looking good and we're making good solid gains, to just load it a little bit at the end of every treatment, I have found has been extremely successful in maintaining the gain that you achieved in the clinic that day. So it just helps hold whatever you did so that the next time they come in to see you, whether that's in 2 days or 6 weeks, that we would expect those gains to stick unless something had changed, another accident. Did that answer your question a little bit? Okay, great.
The other way I explain it is, so now that the shoulder is physically able to do this movement, it has to feel safe. So you run 40 and 89. That's the white part. Don't be afraid to move it. It's going to be fine. But it's like the cerebellum has not ever, like in 3 years, encountered these muscles in their current condition. They haven't been able to move for 3 years. So the cerebellum worked around those adhesions or torn and broken or whatever. So they worked around it, figured it out. Yes, you want to raise your arm, you got to do it this way. Okay. So you just forget that pattern, little 40 and 84. And then what I tell the patients is the cerebellum has like a file card. It's got a folder in there. How do you move the shoulder? First you do this, then you do that, and you do that. So the cerebellum has a program for how to do this for the shoulder. So you run increased secretions in the cerebellum, which I think you call load, right?
Yep, that's part of it.
Increased secretions in the cerebellum, and then everything moves in the right order. And my favorite part in the core is the sensory cortex is the one that initiates movement. So you think the thought, I want to reach up over my head. That thought goes to the sensory motor cortex. The sensory cortex knows where the shoulder is. The motor cortex sends the signal to the cerebellum, but the motor cortex hasn't seen this shoulder in its current configuration in a while. So you do increased secretions in the sensory motor cortex. And what's really fun is to watch
81 and 92.
81 and 92. Yeah. increased secretions, 81, that's on the boat, right?
81's
Definitely. And you take 92, and the sensory motor cortex, the quality of the movement gets smoother because the message from the brain goes to the cerebellum. We've already turned on the cerebellum. Now the sensory cortex is on the boat with the cerebellum talking to the shoulder. Then you go back down and remind the cerebellum, just reconnect the two. And now the movement is not only coordinated, but smooth.
Right.
So that's why I take the central nervous system on the boat with me.
Yes, it has to come.
Yeah,
I believe we're out of time, but we have one more
No.
question that we absolutely have to answer.
absolutely.
So I just wondered if you had any self-care secrets.
Self-care secrets?
Yeah.
Yeah.
I heard that people have morning routines and they have their coffee.
Yeah.
And if you could just run 49 to all tissues for 10 minutes every
Right.
morning, wouldn't that be a really good ROI?
So the question was self-care. And as practitioners, we are probably the worst for treating ourselves. So putting it into our morning routine. So the thought idea was using 14, which is one of my favorites. It's coming on the boat. It is Vitality, running it on either 0, maybe like all of our tissues. I think it's a great idea. I'll tell you a funny story and I'm going to tell it right now.
Go for it.
Okay. So I love coffee. I'm a coffee snob. I love very good coffee. I need my coffee. Otherwise, my family calls me a homicidal maniac, allegedly. So I thought, I'm going to see how well the brain fog protocol works on the custom care. So in lieu of drinking coffee, I am going to run brain fog in the morning as part of my morning routine. I wanted to do it for about a week. I got to about day 3, and my daughter came to my room with a cup of coffee, and she just wasn't down. So I'm not sure that it works. I like the idea because, yeah, like why not use Vitality? But I'll let you answer the question. I just want to share my morning routine.
I like the idea of Vitality, but on the other hand, when you look at what we do, you have to take out the pathologies first.
So again, with Roger Bilica, I have to just bring his name up because I think about, so taking out the bad and putting in the good. So this would be one of those things where, like you said, there's times sometimes where you have to put in the good before you take out the bad. So sometimes I do like to run 49, depending.
On the
I
other
love the
hand,
idea, and I think you should try it, and then you should write a case report and let us know.
and then we'll see you.
And take pictures, like how your skin looks and like how shiny your hair is and what kind of mood you were in. So thank you yeah, exactly. And ask your family how you're doing with your Vitality.
And if somebody hands you a cup of coffee,
Then you know it's time to abort the experience, and experiment is over, and for everybody's health and safety. So we have a closing show and tell, it looks like. We have some Irish whiskey
Do you want me
truffles.
to tell the story?
You need to.
It's a good reason to come to Costa Rica. This is a Costa Rica story. It only looks like Irish whiskey, how do I get that
That's good.
vertical?
Yep.
There we go.
Got it.
Irish whiskey chocolates. We were in Costa Rica for the core, and there are, I think it's bonobo monkeys. They're all dark. So they also had the capuchin monkeys that have the yellow face, but these are fairly larger and they're dark and they're really, really smart. So our practitioner from Ireland had brought the Irish whiskey dark chocolates and left them in her room. And they're filled with Irish whiskey. But we had a thunderstorm, the Meniers lit up. I got so motion sick, I couldn't be vertical. So I made my way back to my room. I said, I just have to take 3 meclizine and sleep this off. I'll be back in an hour. And so I thought the students are just going to be bored. As it turns out, the monkeys had broken into her room. They knew how to operate the slider. That's a good face. So they knew how to operate the sliding glass door, and she hadn't locked it. Well, they found this instantly, opened up the box, and she arrives in a room later to find the chocolates all eaten. But while I was in my room sleeping off the Meniers attack, these monkeys are totally drunk on Irish whiskey chocolates, doing flips and backflips, and the mom had a baby on her chest and she's doing somersaults, and the two guys are swinging back and forth, totally out of it. And the whole show lasted about an hour, at which I reappeared. They didn't even miss me because of Irish chocolates. So this October, we're doing a 5-day core, and right behind it at this beautiful place called Anamaya on the Nicoya Peninsula, on the east side of the Nicoya Peninsula, like really, the ocean is down there. We have a 5-day core followed by a 5-day rehab course. And it's the one for sure that we have booked. So Kim has 2 days and 2 days, and then we have 1 day, 3 days, and then 1 day in the middle that's off to empty your brain, and then 2 days for the second half of the rehab course. So we're gonna do 2 weeks in Costa Rica back to back. And
It's gonna be a fun business write-off.
yeah, you might want to sign up early because they only have 20 rooms, because there's another group there at the same time. And it's hard to describe what Costa Rica does to people. I've never seen my staff so relaxed. Like,
Even Kevin.
oh, Kevin.
Kevin's right there.
Oh, do you remember the time you fell asleep on the massage table during the break?
No, it didn't happen.
Of course you don't. No.
Not
Yeah.
Kevin.
So it's, yeah. And yeah, it's hard to describe this place.
You just have to come.
Yeah, it was enough to get Kim to come to Costa Rica.
Yeah, she sent me a couple pictures and I heard the monkey story. I'm like, sign me up. That sounds like my kind of place.
Yeah.
So
We're having a good time.
that's it for today.
Yes, it is.
Unfortunately. Thank
Yeah.
you everybody for coming. Thank you guys.
Thank you.
And here's to a great advance that's about to,
I'm not going to be here next week because I'm on vacation next week.
as you
I-
should be on
I'm
vacation.
Plugging.
Yes, good for you.
You'll find me in Borrego Springs. Thank you very much, but please don't find me. I'll be hiding out. Y'all have a good week. Do good things. Save lives. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.